This we move on to the next talk by Josie, and she's going to speak on strengthening the continuum of care to eliminate corneal blindness. Over to you, Josie.
Thank you so much, Swati. And let me just... I apologize. I am not seeing an option to share my presentation.
Hover your cursor at the lower edge of the Zoom screen, and then a little black sort of bar will come up, and then there'll be a green thing saying share screen. So just
there we go. Thank you so much, Radhika. Excellent. Well, good evening to those of you in Asia, and good morning and good day to those of you from around the world. It is such a pleasure to join this evening and following Eric's conversation and talk, really a little bit of a gear switch to talk just about our role in ensuring that all individuals who suffer from corneal disease have access to care. And talking a little bit about some of the work that SightLife has done in partnership with eye hospitals in India and Nepal to really bolster the continuum of care. So according to the National Blindness and Visual Impairment Survey in India, corneal opacity is the leading cause of blindness for ages 0 to 49. And the second leading cause overall. It has a huge impact on working age population. And we see this in low and middle income countries around the world as well. Huge impacts on our youth, on those who are in their prime working age. And the impacts of blindness on that age group can be absolutely devastating, whether it is inability to get a job because of blindness, or some type of scarring where people are discriminated against, or lack of ability to go to school, get married, etc. Just massive impact and such a huge impact on the working age and youth population. And when we drill into those causes of blindness, we understand too that in the infectious keratitis and trauma account for a combined total of 68.6% of corneal blindness in India. And yet these causes are largely preventable. If you look at the same combination in China, it's over 80% of the cause of corneal blindness. And if you contrast this with what we see in Western countries, we often see these numbers as less than 10 or even less than 5% of the need for transplantation. While tissue supply has increased in the absence of the pandemic, and it has increased substantially in many low and middle income countries over the last 10 years, there remains a delta. And in general, we are also using a lot of tissue supply and for causes of corneal blindness and disease that often don't have very good outcomes in transplantation as well. And so as we look at this continued delta between tissue supply and tissue demand, and especially with the impacts of the pandemic over the last couple of years, and huge tissue shortages at various periods of time as the waves of the pandemic have hit, there's more that we can do to ensure that only those who absolutely require transplants get them by really bolstering the continuum of care. And historically in eye banking, we've really focused on the top of the pyramid. So if we think about the pyramid of care, we think about corneal surgeons and ophthalmologists providing that subspecialty care and that surgical management. And of course, only transplants are provided by corneal specialists. But we have an entire pyramid of eye and healthcare specialists that can really lean in to provide support and prevent progression to transplants, particularly in cases of eye trauma, where individuals may have a scratch in the eye, and what they really need is access to topical antibiotics so that that does not progress to requiring a transplant. And so it's really important that we as a sector really focus on how we engage our community health workers, our ophthalmic nurses, our AOPs in corneal care, appropriate corneal care, to ensure that people are not progressing to corneal blindness. So a lot of this is about task shifting to other cataracts to ensure timely, affordable corneal care when patients need it. This is an image of a general ophthalmologist in China who went through a multi-day training that Sight Life put together that was specifically targeted at medical management of corneal disease. So not looking at surgical interventions, but recognizing that in a country like China, there are only about 100 corneal specialists in the country and only about 40 trained corneal surgeons. So the mismatch in the population who need corneal care with those who have subspecialty training to care for corneal patients is vast. And in China, the catar that felt like the right opportunity to train for more of that medical management was general ophthalmologists. So really understanding too, in the context of the country, who is the right catar, what can and should they do, and working with corneal specialists to understand and design the training for whether it be general ophthalmologists, AOPs, optometrists, to really support in that medical management of care, and particularly where there's early stage infection. Are there individuals who can really help to support the treatment of corneal disease? And so in China, we have targeted general ophthalmologists. In Nepal, we are about to launch a training in collaboration with the National Association of Ophthalmic Assistants. And in Ethiopia, we'll be focusing on training ophthalmic nurses. So really excited to begin building more capacity among different catars at the secondary and primary care level for corneal care. But we can't forget about the importance of addressing this at the community level as well. And over the last 5 years, Sight Life has been working to translate research, a clinical research project from the Proctor Foundation, which trained community health workers to identify corneal abrasions and provide topical antibiotic ointment treatment if an abrasion was discovered. And we have seen remarkable success in this program. Currently, we're working in 4 districts in Nepal and in the Sitapur district in Uttar Pradesh, India. And in this time, we have our Sight Life trained community health workers have provided first aid eye care to over 50,000 low resource neighbors in rural India and Nepal, ensuring that people don't have to leave their communities to get access to first aid eye care. But if they require more intensive care, they have a clear referral pathway to a tertiary level eye hospital that can ensure that they get the appropriate access to care. And this simple intervention has resulted in a 96% 6% success rate in resolving corneal abrasions with a 3-day course of antibiotic ointment via applicaps that the patients are able to administer after the identification of corneal abrasion, and ensuring that those whose abrasions don't resolve are referred in to the appropriate level of care. Additionally, this last year, we added training to identify pediatric corneal disease and ensure a focus. And we have seen over a 10 times growth in the number of pediatric patients that are coming to be seen at the community health worker, at their local community health worker with the ASHAs, and then be referred in to hospitals for additional treatment. So we're supporting the most vulnerable, people who can't leave their communities, and preventing our women and children and working age population from progression to corneal blindness. So what can we do? One, work with our networks, with our partners, to ensure that when we think about corneal care, we are integrating not only at the tertiary level, but also looking about how we provide training, appropriate level training at the secondary, primary, and community level. Partner with SightLife. We are looking to expand these programs, looking for ways to grow this work. We believe it is critical to honor the loved ones who give their families corneas, as we heard earlier, and finally advocate. The only way we can truly integrate corneal care and eye care at the primary and community level is if it is integrated into the broader primary healthcare system. And so we need partners to advocate for that inclusion. Thank you so much, and look forward to answering any questions there might be.